A very good morning to all. My topic for presentation today is on approach to diagnosis of hemoglobinopathies and the utility of high performance liquid chromatography, which is also termed as HPLC in neonatal screening. So before going to the topic, we will have a brief introduction about the structure of hemoglobin, the disease burden in present scenario, and the types of hemoglobinopathies. We will just briefly see the pathophysiology of sickle cell and beta thalassemia and diagnostic tests that are required for screening and confirmation, and the role of HPLC in neonatal screening and the challenges that are faced. We will have a brief outline of that. And in the end, we will see the statistics in Bahrain and Bahrain Specialist Hospital about the newborn screening. So to begin with, as we know, RBCs are the major transporter of oxygen and they carry oxygen through hemoglobin. So the RBC comprises of hemoglobin, which consists of heme part and the globin part. This is the structural photograph of adult hemoglobin, which is comprises about 97% in adults, and this is HbA. So in HbA, we have two alpha chains and two beta chains. So, and each globin chain is centered by the heme group. We can see the porphyrin ring, and which in turn is centered by the iron molecule. So each porphyrin ring has one, each globin chain has one porphyrin ring and heme group. As we know, during the intrauterine life, the yolk sac is the major production source for RBC, and the globin chains that are produced are epsilon and zeta, and the hemoglobins that are derived are called Gower and Portland. So from which is further the hematopoiesis is carried out by liver and spleen during the fetal life, and as we know, the majority of the fetal hemoglobin is HbF, which comprises of alpha 2 chains and gamma 2 chains. So the fetal hemoglobin comprises of 2 alpha and 2 gamma, and during the neonatal life, we can see the gamma chain will be diminishing, and this will be taken over by the beta globin synthesis, which is carried in the bone marrow. And the adult hemoglobin comprises of 2 alpha and 2 beta chains. And gamma proportion is very less, which will be around less than 1%. And delta chain will be around 2 to 3%. And so in adult hemoglobin, we will have 2 alpha 2 beta chain and 2 alpha 2 delta chain. Which is HbA2. So HbA is 97%, HbA2 is 2 to 3%, and the HbF is less than 1%. So this is the ratio how we have in adult. And in fetal life, as we have seen, majority is HbF. So the chromosomes that are responsible for alpha gene are the chromosome 16. We have 2 genes for this. And for the other globin chains, we have 1 gene which is located on chromosome level. So coming to the disease burden, hemoglobin disorders are the commonest clinically serious single gene disorders with 5 to 7% of global population as healthy carriers. So the WHO group in recent study, they have shown around 300,000 and 400,000 kids are born every year worldwide with significant hemoglobinopathy disorders. And around 60,000 of these will have thalassemia syndrome, and the rest will suffer from sickle cell disease and the other hemoglobinopathies. So this is the disease distribution. The blue color depicts the thalassemia distribution, which is more commonly seen in the Mediterranean region, including the Europe, Middle East, in portions of India and Southeast Asia. While the sickle cell anemia cases are more prevalent in the African subcontinent and parts of Middle East and India. HBC is more commonly seen in West Africa. Similarly, the other portions, HBD, are more prevalent in parts of Gujarat and Maharashtra in India, and HBE is more prevalent in Southeast Asia. So, worldwide distribution of carriers in Middle East, you can see around 5 to 40%, which is the majority in Middle East and Southeast Asia. followed by Africa and other subcontinents. So this is the one of the largest study that was published in 2024 about the variants of thalassemia and sickle cell carriers present in Middle East, especially Saudi Arabian region. And in this, they have shown around 4.4% of the cases were detected for carriers, HBS carriers, sickle carriers, followed by beta thal carriers were around 1.1%, and the remaining were in very less proportion, 0.04 of for HBC and others. So what is hemoglobinopathy? It is a group of blood disorders genetically inherited and characterized by abnormal structure or production of hemoglobin molecule. There are more than 700 HB variants that are currently described to date. And the identification of clinically important variants is mostly required in the screening programs. So basically the neonatal screening program, it is focused to detect the disease and the thalassemia disease, especially the HBS and thalassemia. The pattern of inheritance of hemoglobinopathies is autosomal recessive. So in this kind of inheritance, we know if both the mother and father are carriers, the chances of the newborn to get the disease is 25%, and the chances of the newborn being carrier is 50%, and the chances of the newborn being unaffected is 25%. So coming to the subcategories of hemoglobinopathies, yes, they are subdivided based upon the defect that is happening. The defect is qualitative or structural. As we can see, when there is DNA point mutation occurring, it can lead to the structural defects in hemoglobin. HBS, HBC, HBE, and others are the example. When there is quantitative defect in production of hemoglobin, for example, thalassemias, alpha and beta thalassemias, they are categorized as quantitative defects. So there is one more variant, the hereditary persistence of fetal hemoglobin, where the fetal hemoglobin still persists and there is a failure of fetal globin to shift to beta globin. So most commonly, the qualitative alterations are seen in beta chain, and that what is actually the term disease and trait. So we have to know a disease is characterized when there is a gene mutation in both the globin chains, and hence both the chains are altered. For example, HBSS, in this abbreviation indicates both the genes are altered. So in addition, there can be alteration in another type of gene like HBSC or HBS with thalassemia. So these are also termed as disease. So when it is called trait or carrier, when there is single globin chain is altered. So for example, sickle cell trait, it will be labeled as HBAS. Here A denotes the dominant proportion of hemoglobin. So dominant, this A is actually the adult hemoglobin. So in case of carriers, we have around 10 to 30% of HBS and the remaining is HBA. This is seen in adults. So this is the abbreviation pattern we use, HBAS. Coming to the various types of qualitative alterations. So most common is HBS. What is happening is there is substitution of glutamic acid to valine at position 6, and on peripheral smear we see sickle cells. Similarly, in HBC, there is shift from glutamic acid to lysine at position 6, and target cells are actually seen in all types of hemoglobinopathies. They're not specific to any particular type. I mean to say beta thalassemia or sickle cell or any other hemoglobinopathy can show target cell. In addition, HBC has characteristically HBC crystals that are seen, and these are seen mainly after splenectomy is cases, like because normally spleen will be removing all the crystals or any kind of abnormal RBCs. So when splenectomy is done, like these cases, in these cases only we can see the HBC crystals. Similarly, other qualitative defects will present with microcytic hypochromic anemia, and mild hepatosplenomegaly. So as I was saying, due to sickle cell disease occurs due to point mutation from alanine to tyrosine substitution that leads to glutamic acid substitution to valine. As a result, there is hemoglobin tetramers are formed, and these are unstable and they polymerize. That leads to sickle cell shape. So this sickle cell feature is happening when there are some triggering factors. So what are the triggering factors? Sudden change in body temperature, dehydration, or shortage of oxygen, and infections. So when there are these stressful conditions, so what happens? The HBS polymerizes and take the shape of sickle. And because of sickling, there are two factors happening. One is the direct vaso-occlusion causing the capillaries to get clogged. And as a result, there is repeated ischemia reperfusion injury happening that further aggravates the inflammatory response, and massive inflammatory interleukins are released and that are leading to a repetitive cycle of ischemia reperfusion injury. Similarly, due to because sickle cell is stiff, it cannot pass through the microcapillaries, it gets hemolyzed easily. And because of hemolysis, these heme and free iron radicals are released, and this further will aggravate the inflammasome activation and aggravate the interleukin response and inflammatory reaction. So such kind of injuries are happening at the microvascular level, which is more concentrated in the lungs and kidneys. So in lung, we can see acute lung injury due to pulmonary edema and hyaline membrane deposition because of these inflammatory infiltrates. As we know, the most common presentation with which these sickle cell disease patients present is painful and swollen hands and feet, and with extreme fatigue due to hemolysis and loss of hemoglobin. So if not treated, then the patients can land up into complications like pulmonary hypertension, and due to it, it can lead to cardiomegaly and heart failure. And other septicemia and further due to vaso-occlusive episodes, splenic infarction and avascular necrosis of bones will happen. And finally, the patient will land up in end organ damage. So coming to lab profile, what do we see? Usually we see features of anemia with low hemoglobin, low hematocrit, and low RBC, and a response from bone marrow, which is indicated by high reticulocyte count. So as a result of hemolysis, the features that we can see in the blood is low haptoglobin and high LDH, high indirect bilirubin. And of course, HBS can be demonstrated in electrophoresis, and inflammatory mediators can also be noted in the blood. Coming to the quantitative alterations, starting with alpha thalassemia. Alpha thalassemia, we have two genes that are expressed per chromosome. So total, there are 4 genes. So basically, the severity is correlated with the number of gene deletions. And among these deletions, the cis deletions are show more severity than the trans deletions. So when there is one deletion, it is called silent carrier. When 2 deletions are there, cis or trans, it is seen in alpha thalassemia trait. And in these both conditions, like we may see microcytic hypochromic anemia or may not see. But I mean to say, microcytic hypochromic anemia is very minimal because the alpha globin output is still 50%. So when the alpha globin output is reduced than 50%, then only the features of hemolytic anemia and microcytic hypochromic anemia picture will be visible. So when there are 3 deletions, the phenotype is HBH disease, or where there is complete shift to beta tetramers. And when there is no alpha gene, there is complete shift to gamma globin, and this is not compatible with life, and the cases will be detected as fetal hydrops. So coming to beta thalassemia, the gene expression is seen in one gene is expressed per chromosome. So total 2 genes are required. And based on this, they are classified into major and minor. And beta plus is the abbreviation used for milder expression, and beta 0 is used for absent expression. So a majority of us know that target cells can be seen, more commonly seen in thalassemias. So basically what is happening when there is loss of globin production, the cytoplasm, actually RBCs comprise mainly of cytoplasm. They don't have any other organ. So the reason for target cell is disproportion in the cytoplasm to the cell wall. So when we are looking from above, as the hemoglobin is reduced, cytoplasm is also very less. I mean, the density is less. So we appreciate this kind of dipping or cupping from above. So this gives us the impression of target cell. And so coming to pathophysiology of thalassemia, what is actually happening is there is shift of hemoglobin into other forms, like when beta beta globin chain is deficient, the body shifts to product synthesis of fetal and A2 HbA2. As a result of this, the free alpha globin which is there, that gets accumulated, and that is very unstable and leads to reactive oxygen species, and that further causes hemolysis. This is the characteristic phases which we know about thalassemia. The chipmunk phases, like where we see the maxillary bone enlargement and protrusion of the upper jaw, nasal bridge shortening, so widening. So basically these things are happening because of excessive marrow reactivity. Marrow is trying to respond and release other forms of hemoglobin, but it cannot completely synthesize the other forms. So what are the methodologies to detect hemoglobinopathy? So initially we have to do RBC count and in CBC profile along with retic count. And there are HB quantification methods which are currently available, like capillary electrophoresis and HPLC. So HPLC and capillary electrophoresis are the major quantitative tests. Like earlier, agarose gel and cellulose acetate electrophoresis was used. In that, the drawback was we were unable to quantify the exact percentage of HbA2 and F. So there are additional other tests that are available, which is isoelectric focusing and DNA analysis for confirmation. So in CBC, what are the features that we see is reduce hemoglobin and increase RBC count, reduce MCV, MCH, and increase retic count. So RDW will be normal. And as we know, in iron deficiency anemia, RDW is decreased. So that helps us rule out iron deficiency versus thalassemia. So when we see CBC report, we have to make sure we have to note down the Menzer index. So this is one of the hint that we are looking at a case of thalassemia or iron deficiency anemia. Menzer index is calculated by MCV divided by RBC count. Suppose this is one of the CBC picture where the RBC count is high, hemoglobin is slightly reduced, but the MCV, MCH is very disproportionate. So this is one of the hint to the amount of hemoglobin that is reduced is not proportionate to the MCV. And we can see RBC count is very high. Menzer index will be more than 13 in this case. So it indicates beta thalassemia. Less than 13 indicates beta thalassemia. So one more differential what we have to keep in these conditions is we have to ask for peripheral smear to look for giant platelets. So whenever giant platelets are there, the machine can interpret the RBCs with platelets. So as a result, this kind of picture may also be seen. So this is a microphotograph of beta thalassemia, where we see target cells, marked anisonucleosis, increased reticulocytes, and NRBCs. This is from a peripheral smear of HBC. We can see the HBC crystals. These rod shaped are the HBC crystals. And this is from the sickle cell disease patient, where we can see sickling. These are the sickle cells or drepanocytes. In alpha thalassemia, HbH disease, by special stain, reticulin stain and special dyes, we can see characteristic golf ball appearance of the RBCs. One of the screening modality that is also available is the solubility test. This we have in our lab. So we can, this is used for HbS screening, hemoglobin S. So what happens is, because of polymerization, the deceased patient will show turbidity on addition of buffer. So the background lines are not visible. These are few of the earlier modalities that were used. As we know, electrophoresis, cellulose acetate on alkaline medium and acidic medium. So the drawback was like these were having the other hemoglobins, hemoglobins in the same zone. So, but one more drawback was there was no quantification of HbA2 and F, that is more required for diagnosis. Similarly, isoelectric focusing, it separates the hemoglobin bands based on the current passed and the isoelectric point or isoelectric pH the particular hemoglobin will attain. Coming to HPLC, so this is the recent modality that is commonly used for screening of newborns and adults for hemoglobinopathies. So the machine has buffers which push the lysed sample of patient through the capillary cartridge, where the cation exchange happens, and the final reading is being analyzed by the computer software, and that gives the result based on the elution time. So what is happening? The exchange is happening in different times. So the final result is interpreted based on the elution time. So one point of concern here is it needs a good interpretation skill and good expertise in reporting hemoglobinopathy, because there are few bands that overlap in the time zone. For example, the HbA2 window will have overlap of A2, HbE, and LEPO. So these need to be correlated clinically, as well as there are some specific patterns where we can identify these. This is a typical graph of Hb electrophoresis. So because of the near elution time in E, A2, and E, these all will be overlapped in A2. So these are few of the technical aspects which we need to consider while reporting. The HbF value is normally less than 5, because in some normal adults also HbF can be 3 or 4%. So in pregnancy also it will be less than 5. I mean to say it's not exactly 1. It can be slightly elevated because of hemodilution. And in patients of anaplastic anemia or a patient on chemotherapy, the values will be around 5. So when there is a slight increase, we have to suspect beta thal trait, and homozygous beta thal is detected when the values are more than 15. More than 15 degrees. So there are molecular modalities to confirm. PCR restriction fragment like pleomorphism is commonly used, where the PCR will detect the specific DNA of interest and then analyze on gel electrophoresis. Similarly, Sanger sequencing can be done that will polymerize the DNA fragment, and then it will be detected by laser fluorochromes and computer analysis. So the newborn screening program basically suggests us to have two screening methods. So from primary screening method, if any abnormality is detected, we have to go ahead with secondary screening method like HPLC or the capillary electrophoresis. Or in addition, if we can add DNA confirmation studies. what is the sample required? It is EDTA, the routine sample that we use for CBC. Fresh blood is preferred, and analysis done within 24 hours gives best results. In addition, cord blood and dry blood can also be used. So this is a diagram for approach how to deal a case of microcytic hypochromic anemia. First, we have to do serum ferritin levels. If there is iron deficiency, we have to correct it. Then again, do HPLC or HB electrophoresis. And once HbA2 is more than 4%, then we have the possibilities of thalassemia trait or thalassemia intermedia. And then we have to look for HbF to categorize further as thalassemia intermedia or trait. And when the values are less than 4, yeah, it can be alpha carrier or it can be a normal individual. So the silent alpha carriers are basically missed. I mean to say the silent alpha, the 1 gene and 2 gene deletions are not detected in HPLC. So because the HbA2 pattern is similar to the normal individual. Only HbH disease we can detect among the alpha carriers. And how is HbH? There is a small peak in the initial phase. Because the peak is very less, so in few of the cases it might be missed, but HbH we can see with confirmation by reticulocyte gall appearance also. So this is the peak which I was talking about, pre-run peak of HbH. And this is from a case of beta thalassemia carrier. HbA2 is 4.5. As we can see, F is not elevated and A is 95%. These are few examples from other conditions like HB Lepore. HbA2, as I told, HbA2 overlap is there with HB Lepore, HBD Iran, HBD Punjab. So we have to be sure to notify that A2 value is around 10% to call it as Lepore. And we have to use other electrophoresis method also like capillary electrophoresis, which further categorizes it as separate wave. We can see this is the right side is the capillary electrophoresis that has categorized as separate wave. Similarly, HB heterozygous will present as HbA2 value of 26%. HBD Iran will show HbA2 percentage of 40%. One more thing to mention is hereditary persistent fetal hemoglobin versus delta beta thalassemia cannot be differentiated in neonates, but in adults we have some soft clues that we can differentiate this. And we need to correlate this with the clinical features of microcytic hypochromic anemia. So in hereditary persistent fetal hemoglobin, there will be normocytic normochromic anemia, while in delta beta, there will be microhypopicture. And these are a few more patterns which we need to consider while reporting. So in addition, we should be aware of few factors that are responsible for low HbA2 and that can mask beta thalassemia traits. For example, iron deficiency, anemia of chronic disease, and sideroblastic anemia and hypothyroidism. These all will have effect on HbA2 values. And HbA2 value can be elevated in conditions with raised B12 or folate with B2 and hyperthyroidism. And blood transfusion, if given within 3 months, I mean, patient has to be advised to do after 3 months of blood transfusion. Yes, as I told earlier, silent beta thals can be missed, and HbA2 coelutions has to be taken in mind. So neonatal screening, one more issue is majority, as we know, majority of the hemoglobin is HbF. So we are actually seeing at only 20% of the hemoglobin. So now this becomes the problem. That's why it is advised to repeat after 3 months so that the other portions of hemoglobin which are abnormal that can be eluted. So similarly, the alpha thal carriers, singular two gene deletions will not be detected, and that has to be confirmed with DNA studies. So in any case of abnormality, it is better advised to do parental screening as well. So this was the largest study done in Bahrain. where they have done newborn screening from around 25 years, and they have shown that the incidence of as a result of screening, the sickle cell disease burden has been decreased dramatically. So in 2009 and 2010, 10, there was very less, around 0.6 to 0.4%, while earlier years were the disease was around 2.1% population. This is the HPLC data at our hospital. We started this testing 2 months back, and we have screened around 84 cases of neonates. And in this, we had 5 cases of sickle cell carrier and 1 alpha thal carrier. In adult screening, we did around in 34 cases, and we found one single sickle cell trait and disease, 2 beta thal carriers, and 1 HBE carrier. Thank you.
Thank you.